Okay, we're just going to give it a minute or so for all the attendees to come in from the waiting room. Okay, I think that's good. We'll have people join us as we move along. Good day, everyone. My name is Dr. Neeraj Mistry. I'm the Chief Medical Officer of the Fatty Liver Foundation, and welcome to the second in our series called Live for Liver Health series, Live being Learn, Inspire, and Value. This is our first alcohol-related webinar, and it's called Understanding Alcohol-Associated Liver Diseases. This particular series has been made possible with a grant from Madrigal Pharmaceuticals. It's one of our favorite, very patient-centric and patient-friendly biopharma companies. So we are grateful for their support for this webinar. So we have a wonderful panel lined up for today, and we're going to explore all issues related to alcohol-associated liver disease, but also alcohol disease much more broadly. So our next slide, please. So just in terms of disclosures and disclaimers, this webinar is for informational purposes. We are not prescribing any particular treatments or managements. We will talk about many, but it is incumbent upon anyone who's listening to discuss management options with their primary care provider, with their specialist providers, etc., because each case is different, and we don't want to make such big generalizations, but customization with your care provider is important. Next slide, please. So this is a slide we've used quite often, and like the universe, which is constantly expanding and contracting at the same time, so is this gathering storm with MASH, metabolic associated steatotic liver disease. And the challenge has been well, one, it's definitely the leading cause now of liver transplantation. So it is this growing epidemic that we're seeing. We've seen challenges with the diagnosis of it, given that it used to be liver biopsy, and then we've got scanning technologies. But while those challenges have been there, we're also now entering the realm of non-invasive tests. So that landscape has been changing. Previously, we didn't have any treatment, and now we do have a treatment for it. And so that has been a game changer in many situations. And because of the projected costs related to transplant and dealing with all these issues, we can now see some respite in it if we have these interventions early on. One more element that I've added to this storm is the psychosocial and medical disease etiology and response. And I think increasingly, with medicine and public health, we're starting to see those social determinants of health. And when it comes to alcohol-related disease, they have a huge impact in etiology and progression of disease. Next slide, please. And then just with a change in nomenclature, and this is definitely reflected in the fact that the Sober Liver Society, led by the wonderful, charismatic Jen Jones, has become part of the Fatty Liver Foundation family. And under one umbrella, we are addressing both the steatotic liver diseases caused by a host of factors of all the comorbidities, as well as alcohol related. And these are the two boxes in the middle, I think, that are most important for our discussion today. That's MetALD, which is MASLD, and increased alcohol intake. And I think it was a valiant effort by the liver community to try and capture the balance of alcohol use and the non-alcohol part of this, or metabolic associated part of this. And then we also have alcohol associated liver disease, ALD. That's with mainly alcohol use. Okay, so that is just to sort of give a broad sense of the overview of what we're dealing with for today's conversation. And could I get the next slide, please? And to help us walk through this, we've got people from or specialists from both sides of the issue when it comes to alcohol. So first is Dr. Suthat. who is a professor of medicine, biochemistry, molecular biology, and a professor in anatomy, cell biology, and physiology in the gastroenterology department at Indiana University. And he'll be sort of walking us through more of the biological side of things. And then we have Dr. Robert Weinrieb, and Bob is the chief psychiatric consultant at Penn Transplant Institute. And that specialization in the field of liver health with psychiatry is quite a unique combination as well. So welcome, friends, and thank you for joining us today.
Thank you.
Thank you for having us.
Excellent. So to dive into things, I found this wonderful slide that talks about alcohol use disorder as a spectrum. And so it's not one single entity, but there's just such a wide range of it. And I wanted to put this up and get your reaction to this particular slide. So Bob, do you want to start?
Yeah, sure. So essentially, I think the slide is stating that alcohol use disorder comes in many different varieties or flavors and severity. And so, for example, there are people who don't have what would be considered severe alcohol use disorder, but still have liver disease. And so the alcohol use disorder is one part of the problem, but the problem itself physically is extremely debilitating, and the effects of that are very wide-ranging, and therefore there's also a lot of psychosocial, psychiatric, emotional aspects to the recovery of this, and also with the disease itself. But you can see people who have extremely severe alcohol use disorders where their lives are really torn apart by the alcohol use, and there are other people who've managed to continue to live their life, albeit not as well as they could without the alcohol. And both of those groups can sometimes have cirrhosis and alcohol-related liver disease.
Excellent. And Suthat, over to you.
Yeah, I think from the non-psychiatrist perspective, I completely agree with Bob just said, but I think as a physician or clinician taking care of these patients, I think we also have to be mindful that there are a large number of patients that drink alcohol very heavily. You know, these are the people who have excessive alcohol use beyond the recommended definitions or guidelines. But these patients do not have or reach the spectrum of alcohol use disorder. So I think this is so important that, you know, even though when we see patients, you know, you can do any screening questionnaires that, okay, you don't have AUD or alcohol use disorder, but doesn't mean that they don't have excessive alcohol use, because that's, again, the spectrum, right? Because you drink, all of our alcohol use disorder have excessive alcohol use, but not all people who have excessive alcohol use have alcohol use disorder, because AUD also have to have issue with the social or other health consequences. So I think we have to be mindful. You know, we use the term AUD, ALD a lot, but again, the another spectrum before AUD, those are the one too that we have to be more mindful and take care of as well.
And I think that's a really important point that both of you raised. So we're talking about a spectrum of a disorder in terms of severity, right? And we're saying that people have a different susceptibility to alcohol use that manifests as different severity. But then in addition to that, we are also talking about a range of diseases that result from alcohol use. And those manifestations are different in different people as well, right?
Mm-hmm. Yeah,
okay.
Absolutely. And the diagnosis of an alcohol use disorder in the field of psychiatry is spelled out in our Diagnostic and Statistical Manual of Psychiatric Disorders, the DSM. You may have heard of it. And there are a number of specific criteria that you have to sort of get the diagnosis, if you will, of an alcohol use disorder. And one of those is that you have to be drinking enough alcohol to cause severe psychosocial problems in your life so that you have difficulty controlling the alcohol use. And so one question we might ask people is, have you ever thought about trying to cut back or stop? And if you have, has that been difficult for you? Have you noticed that you've stopped and started a number of times, indicating loss of control, which is really one of the most foundational aspects of the diagnosis of an alcohol use disorder. So even in that regard, it doesn't really, we're not really looking at how much alcohol you're drinking. It could be a very moderate-ish amount of alcohol, but if it's causing problems in your life, whether it's affecting your ability to go to work, go to school, take care of your family, those are the things that are actually a little bit more important, but not the whole story. Many people who are on the heavy drinking side will have tolerance to alcohol, meaning that over time, they will need more to get the same effect or to keep themselves from going into withdrawal from alcohol. And that's another aspect of it. But usually, one of the questions I'll ask people is, did you think alcohol was ever a problem for you, my patients? And virtually all of them know, and they say yes. Down in their heart of hearts, they're aware of it, but then they get stuck at that point. They don't know how to stop. They don't know if they can stop. They're afraid to stop, or they've tried and it hasn't worked. And so in that regard, it really is an alcohol use disorder. And for many people, that also goes along with being dependent, which indicates needing more to get the same effect, and also having withdrawal symptoms. When people slow down or stop their drinking, they might get shaky, nauseous, sweaty, blood pressure can increase. And in many cases, it can be very dangerous. And you really need to see a physician to make sure that that alcohol use disorder in the withdrawal state doesn't cause significant problems for your health, because it can if it's untreated.
Absolutely. Tiffany, can we have the next slide? And then I want Suthat to sort of build on those comments. And here, we have the DSM criteria up as well. And we won't go into it. It's a very geeky psychiatry thing to go through those classifications. But what I do want to ask is, Suthat, from your experience looking at those classifications of risk, how does that correlate to the manifestation of, or to correlate to physical disease that is developing in patients? And there's certainly an acute and a chronic phase to that as well.
Yeah, I think you are referring to how this related to alcohol associated liver disease that we commonly see. I think if you go by the data, right, there's some sort of correlation between the amount of alcohol consumed and the risk of alcohol-induced liver injury. Now, when you go to look at this spectrum, as Bob just mentioned, a lot of times when we see patients, we try to ask the quantity of the amount of alcohol consumed, and also, how long and what's the duration. So I think, when we look at this, again, I want to go back to what Bob and what I just alluded to earlier. We have to try to split them a little bit, because AUD is a spectrum. And then as Bob just mentioned, when you give the diagnosis of AUD, there are multiple components involved. Not only you drink a lot, you also have social issue, dependence issue, and other stuff that related to or as a consequences of heavy alcohol use. I think as a hepatologist, again, this is speak myself, I don't know my colleagues out there. I think the first thing first, when we see these patients in clinic, or when they have a diagnosis of fatty liver disease or steatosis, that you may think about alcohol, not metabolic associated, there's a lot of time going to be very simple questions. How much do you drink and how long do you drink? I don't think, at the first encounter, we may not be able to link that to any other consequences or the spectrum, as you just said. But again, the next step I think is so important to dig deep into, are there anything else that, evolving around problems with alcohol use, because they're going to lead to the treatment and management, because, you cannot attacking alcohol drinking alone if the patient have also other problems ongoing. So I think that's how I approach this. I don't know exactly address your questions, but I think as a rule of thumb, hepatologist, amount of drinking, more the patient, you have to dig deep into any other problems evolving around. I don't know, Bob, people go to see you may be different than come to see me. I don't know, what is your approach? I mean, are you looking at this as your, I don't know, I would love to hear from what you do in your practice.
Sure, I'm happy to try and describe what I do. So I also have a spectrum of behavior in my job. But when I am asked to see a patient, who has alcohol-related liver disease, I view my job as to try to determine what are the challenges this person faces and what are their strengths. And then based on that, I try to create a plan of care so that they can get ready for whatever is next in their care, whether that be a transplant or if they don't need a transplant. But the bottom line here is, how do you live a sober life? How do you live life without drinking? And what did the drinking mean to you? So I actually don't start with how often you drank and how much you drank, because in my experience, a lot of patients kind of get a little put off by that. And it's kind of an intimidating question for them. And they may not want to face it out of embarrassment and shame, which I completely understand. And so I'll start more with the psychosocial issues and kind of get into, at what point, did you recognize that alcohol was a bit of a problem for you? Or did your family ever say anything to you? Or did you have people at work mention something to you? Those kinds of things, to see whether or not they have insight into how the world sees them and their alcohol problem. And the idea is to try to move them to a point in their recognition of their problem that will allow them to accept help for their problem, to accept treatment. And treatment can be variable. There's individual treatment, there's group therapy, there's combinations of these things, there's inpatient and outpatient therapies, and I can get into that if people are interested. But really what I'm trying to do is elucidate or clarify for myself and for the patients, what are you facing in a life without alcohol, and how can we help you face that without feeling like you have to go back to drinking if things aren't going well? And if you do go back to drinking, how do you quickly get back on track before it becomes a big problem again? So these are the areas that I tend to focus on. I try to explain to my students, my residents and fellows, don't start with how many times did you drink this week and but more like, so let's talk about the problem here. It's why we're here.
I love your two comments, because the juxtaposition of it gives us a really good multidisciplinary or transdisciplinary view of the issue. And I think in medical science, we often look for those objective factors, like we can objectively say this number of units of alcohol over this period of time, but we know the impact is different from each individual. But at the same time, Bob, that individual level consultation to understand risk at the individual level is such a specialized function. So it's almost like we need a tool, new types of tools of risk stratification that combines the physical risk together with the social risk. And I don't know whether that's at a professional or community level, and we'll have opportunity to expand on that further. Let me see if you have any additional comments to that.
No, I think that's a suggestion that, we're always striving for. And kind of when we talk about risk, I think there's two ways of looking at it. There's the risk that has been posed already for these patients and what led to it. So by the time I see somebody, they're really being evaluated for transplant. So there's already no doubt that they have end-stage liver disease and that they need a transplant in order to survive. And therefore, in some ways, the exact amount of the alcohol is less relevant to me than how do we maintain your sobriety, because most people have achieved it on their own. But then they're sort of resistant, reluctant to get treatment for it, because understandably they're proud of quitting drinking on their own, because that's a big deal and they should be proud of it.
Right.
What they have trouble seeing is the future and understanding that, yes, they've stopped, and who wouldn't stop under their circumstances? You know, when you're that sick, it's almost inconceivable to think about going back to drinking when you're that sick. But a year after transplant, 2 years, even 5 years after transplant, people do go back to drinking. And what I want to do is provide them with the tools to recognize ahead of time what puts them at risk, back to the risk issue, of falling back to drinking, so that they can preempt that, put something in its place, talk to somebody, not be alone. As they say in recovery, if you go to AA meetings, they have a statement that says, you know, halt, never let yourself get too hungry, angry, lonely, or tired. And those four things, I think, and often with simple sort of acronyms and messages to patients who are just trying to figure out so much. It's such an important part of their life. And at the same time, juggle being sick and going to doctors. You can't throw too much at them. You can't change their life in weeks. But they do need to understand that they're always at risk for the rest of their life. There is no cure for alcohol use disorder. You manage it like you manage diabetes or hypertension, and you don't do it alone.
May I ask a quick question for Bob? You know, when you use the tools or whatever clinical tools that, you know, individualized for each patient, and if, you know, you identify that this patient may be very high risk to go back to drinking, in your clinical practice, do you treat them or follow them differently? And if so, how do you do that clinically to make sure that, you know, to prevent return to drinking from happening?
Well, great question. Thank you. We can't always prevent it, but in those cases, we look at this as almost harm reduction. And so some of the tools that we use involve family therapy, because in my experience, if you have family, loved ones, or people who are your friends and care about you, you're going to be in much better shape than if you try to do this on your own. It really doesn't work very well if you just recover on your own. I think that's one of the reasons why self-help 12-step meetings are so effective for many people who do the work to stay in those meetings, because they don't feel alone. And what we did at our center is we created a treatment program specifically for people with alcohol use disorders and liver disease. And they get into a group that's 12 weeks long. At the same time, they see individual therapy and therapists who've been trained to know about liver disease. So they know what these patients are going through. And really, what's astonishing to me and really heartwarming is that these patients really support each other. So as I mentioned earlier, sometimes they have a hard time feeling like they fit in community alcohol treatment programs or AA meetings. But I would encourage every program in the country, if they can, or anywhere, to try to develop treatment groups specifically for this population of patients, because when they're together, it feels safer for them to open up. And they use a lot of humor, and they really support one another, and they'll stay in touch after the treatment is over. They've formed an alumni group, you know, so they taught me that the best type of self-help actually comes from themselves within the group and toward themselves, if that makes sense. We also use medications for craving if they need it. And we sometimes use those ahead of time, prophylactically, because it feels like for them, the anchors that they're dragging around with the craving and the urges to drink get cut off somewhat and allow the boat to go freely and go faster with less fuel when they're driving the boat. And that's what these medicines can do. They don't make you sick. They don't get you high. They're not addicting. They're safe in liver disease. and they can be very effective. So we use a combination of individual therapy, group therapy, and medicated assisted therapy when needed.
Thank you.
Mhm.
That's great. Tiffany, can we move to the next slide? I think something that's coming through really nicely is this sense of solidarity that we need to build. And you know, the tools we talked about, everything from family therapy to harm reduction and groups by disease and severity are all quite helpful. Something that Jen and I often talk about is through this peer support networks. But very often, it's hard to talk just about alcohol use disorder with liver disease without looking upstream of who is at risk and how can we get to them through peer support networks. And I think these biological pathways, and sorry for the busy slide, perhaps the two of you could just draw on those aspects that jump out at you. Because how can we find these sorts of networks and solidarity to address risk at different levels, both on the bio side, biological pathway, as well as the behavioral pathway, when we look at it this sort of way? Yeah, go ahead.
I think to me, this slide clearly show that, you know, we have to work together on both Bob's side as the, you know, addiction specialist or psychiatrist, and on us who is on the other end, on the biological pathway. You know, the change in immune response can lead to so many things. There's a complication of liver disease. Again, it's so clear that, you know, when the way I approach this patient, when we have a patient sit in front of us, just Neeraj just said, you know, sometimes on my end, we try to look into the diagnosis, make sure that this is the cause of the disease. So the way we frame the question is completely different than when Bob sees these patients on your end. You know, when you say that the way you approach is completely different than, and again, I think it's because of, you know, it's a different specialty, and then I think we can learn from each other in order to how to improve and how we can improve and do better to improve the care of these patients. Actually, you know, these patients that we see, they have two diseases in one patient. And you know, this slide also show clearly on the right, that's maybe in the Bob's territory. The left maybe is my territory. In order to get into the middle, it's just like a two Venn diagram combined together. I think we need to work together. None of us that I can know more from what Bob just described. I think that make so much sense. But you know, we need to learn how we can hone that skill on our end in order to improve the care of these patients. I don't know, Bob, you have any thoughts on this?
Yeah, Suthat, I think that's a really important segue into what I view as probably the strength now, and maybe the best change in the history of our working together. You know, I've been doing this for over 30 years, and when I first started out, I did a fellowship in addiction medicine, and I got interested in transplantation, liver transplantation for alcohol use disorders early on in my fellowship, and wrote a grant in that area to study it. And one of the things that struck me early on was that you can't really separate these things. That as a physician and a psychiatrist, I have to know exactly what's going on in the biological pathways so that I can help patients understand this too. Because, you know, you guys are busy and no one expects you to spend as much time with them as we do. And so I try to take that opportunity to teach them about how alcohol affects their immune system and their body. And what is alcohol? Is alcohol just, you know, brown liquor, or is alcohol beer? And the answer is yes. It's all the above. But lots of people don't know that. They'll come to me and they'll say, but I just drank beer. How did this happen? Or I know 10 other people who drank as much as me or more than me. Why did I get liver disease? And so we talk about that, and I try to help them recognize that some of this is genetics, some of this is other diseases that add to the risk of getting liver disease. But the bottom line is that you hold the keys. You can actually help yourself to stay healthy later. And not drinking is really the way to do that, which on the face of it sounds very simple, but as you all know, it gets tied up in lots of other areas, including, how do people handle stress? How do people handle painful emotions? How do people celebrate without drinking? It's everywhere. Everywhere you look, everywhere you go, television, radio, alcohol's everywhere. How does a person try to navigate that when they know that the risks are so high for themselves physically and physiologically? So do we try to identify those risks? Yes. And we do it on many different levels, which includes psychosocial, like, do they have good support systems? Do they understand what the risks are to going back to drinking to themselves physically, but also in their family life, in their work life, emotionally? And how can they manage those things if they run up against it again? So, for me, I try not to separate them. I spend a lot of my time explaining what's going on in your office to them and to their families. And we know you tell them all these things, but it takes a couple times before they sometimes really get it, and it applies to them in a way that makes sense. And I think that's partly because there's an emotional aspect to getting the news that you have alcohol-related liver disease. That really makes patients feel some kind of way. And a lot of times that way is ashamed and guilty. And that shuts down hearing the messages that you guys are trying to give them. So we work together on that. And what I've been so excited about, and I started by kind of talking about this, is that hepatology, liver specialists, and psychiatrists are now working side by side at the same time in co-located clinics. And we have this at our program. It was initially started at the University of Michigan, and prior to that in Europe and Italy and other places around the world, where the hepatologists and the psychiatrists see the patient, one after the other, and then we huddle and talk about what we've seen, and then we go back and talk to the patient together sometimes. And what that does is it presents the patient with what we know, that this is a disorder that they have that encompasses both fields, and both fields are working together to try to help these folks get better as quickly as possible, but also to maintain that success.
That sounds beautiful, and I think that is the ideal model that we need to replicate in many centers. As a public health physician and a patient advocate at the Fatty Liver Foundation, I want to add a third leg to a tripod stool here. And so we have the biological and we have the psychological, and I think it's worth calling out the social component of this. And these are the peer education networks that we need to establish. And when you look at retention of information that patients have in a doctor's office, when you look at how their lifestyle needs to change at home, which is different from a health facility, that level of community-based support is so important. And I think we need to find those models of how we integrate that into the care plan as well.
Agreed.
I agree. Yep.
Yep, go ahead.
No small task. I mean, one sort of very dangerous and typical example that we see is, a patient who comes in with the liver disease from alcohol, stops drinking, they agree it's a problem, they start getting some help, but they live with people who drink. How do they handle that? How do they face that? Do they force people in their lives to quit drinking so that they themselves don't feel at risk? Usually that can't happen. But, these are the kinds of issues that we do face. And I think that leads to very high risk of people going back to drinking.
Absolutely. Tiffany, can we move to the next slide, please? So for everyone on the call, I just included this slide, which is from the Center for Diseases Control, which, just for the sake of completeness, I think it's important for us to look at the multiple impacts of alcohol use, both on the short term as well as the long term, and then there are social and wellness impacts. And my key point about this is that this is not a pathology that's developing in isolation, but it has such multiple impacts. Do either of you want to comment on any of these?
I think Suthat is probably a little bit more a little bit more well-trained for this kind of answer.
Yeah, I think again, these go back to the spectrum of alcohol use disorder. I think, I think on the left column, and these are the people who have excessive use. Again, these patients who use alcohol excessively, they may not have AUD. But this is a very, immediate consequences of acute alcohol use. As you can see, motor vehicle accident, violence. So I think this is more like acute exposure in a very high level.
Right.
Most of these are binge patients that you can have this, I think, in my opinion. And then in the long term, I think, the recent, the statement from the Surgeon General just talk about, how alcohol is part of a carcinogen. That's why it can cause cancer. And again, biology, there are multiple reasons why this could happen. And again, this may be something that we can see in the long term. Not only liver disease, though, alcohol, once you drink, can affect the whole body, brain, heart, pancreas, liver, muscle even. So I think go back to, when we see patients or advise patients, I think how to screen these patients early on is so important to prevent the long-term outcomes. We did not even touch upon, are there any strategy or tools to screen at-risk patients even before they have liver disease? I'm talking about screening for AUD and alcohol use. Bob may know, in the VA system, it's not like audit C is part of the vital signs. You may know this, right? In the cover sheet, you have audit C as part of it. How can we do this in a large scale? I would love Bob to especially what's your thought on this? We audit has been part of the vital signs and cover sheet at the VA system for a long time. And then this help primary care provider to detect those who have a high score, to do brief intervention. But how you do I think the problem of these, not the problems, this slide emphasize how to screen for AUD, excessive alcohol use, at the population level in order to prevent all of this. Because when they develop all of these, I think it's too late. I don't know, Bob, what's your thought on this?
Well, yeah. So you raised the notion of using structured instruments or pen and pencil questionnaires to identify the alcohol use disorder or even the severity of that. And there are many that have been validated and used over many, many years. And as you said, in the VA, the audit, which is the alcohol use disorders identification test, comes in two sizes, large and small. And the small one is a lot quicker to do, and there are less questions involved. And it gets to the, sort of the root of what is what you see in the DSM questionnaires or the DSM criteria. Is there loss of control? Is there craving? Is there adverse psychosocial effects of the drinking that you're aware of? Have you tried multiple times to stop without success? And have you run into problems with injuries, with violence, with overdose, all these things, sexually transmitted infections, all of these things that can happen, sort of are folded into this diagnosis. The screening questionnaires don't ask these questions so much as they ask the psychosocial questions. And, patients will answer these questions and hopefully answer them honestly to themselves as a way of recognizing that they are at risk of developing these short and long-term disorders should they continue to drink. So, I think there are studies that have shown, you mentioned brief interventions, that you can train primary care doctors to spend just a couple of minutes with a patient, first identifying the problem, and then secondly, using some of the brief intervention strategies to help people stop or slow their drinking down, and then follow up with them again and see that whether it's helped, whether it's worked. The thing about that is that it tends to work well for the more mild to moderate alcohol use disorders, but for severe alcohol use disorders, really, I think a lot of times those patients need professional formal treatment. They need to be in an alcohol treatment program. That's a physician is involved, psychiatrist is involved. They have counselors who are trained in addiction treatment specifically. They have degrees, advanced degrees in this area. Those folks really need that. Everybody can benefit from it who has an alcohol use disorder. But I think doing a brief intervention in somebody who has a more severe alcohol use disorder, who is really at risk of all of these things on this slide, needs more. And often it's psychiatric care too, which is treatment of anxiety, treatment of depression, treatment of phobias, treatment of whatever. And we're there to identify those things and treat them at the same time too. An example is that, a lot of times I'll talk to people about when they started drinking and what did they like about it? How did it help them? It isn't just a problem for them, obviously. They did it initially because something was good about it. And the answer is maybe they like to feel different, or they like to forget about what was going on in their life, especially trauma, which makes a lot of sense. But sometimes it's that they have severe anxiety disorders, social phobia, that they're very, very shy in public, that when they try to speak with other people, they get all tongue-tied and they don't know what to do. And they learn that alcohol can allow them to be more involved socially and feel more relaxed. And so for them, it might work for a while, but then the alcohol problem becomes a problem of its own. And it no longer is helpful. It interferes with things. So you want to go back to that so that you can, if you take the alcohol away, you can treat the social phobia, because that's not gone. They still haven't learned the tools to manage that social phobia, that anxiety, without the alcohol. So I think therapists, counselors, psychiatrists, we look at those underlying disorders and how they affect the drinking in a way that perpetuates the drinking and makes it hard for them to stay stopped.
That's a really good response. I want to move to the next slide, which just talks about some of the social and wellness impacts. And I think we've touched on a lot of these aspects. But I want to sort of draw on one of the questions that were asked, and please, for all the other participants on the call, put your questions in the chat box or in the Q&A function. And Tiffany, we can go off the deck now. Thanks so much. So this is quite interesting now that we have alcohol as well as all the other factors related to steatotic liver disease under one umbrella. And one of the things we've often talked about is different etiologies, but similar journeys. And similar journeys in the sense that there's a behavioral aspect to it and a biological aspect to it. And from your experiences, what are those similarities and what are those differences? I mean, one could talk about a fat addiction in a diet, like there's alcohol addiction, and abstinence from fast foods is sometimes as hard as abstinence from alcohol. So tell us about those and how they may be common risks, but also common healing pathways.
Suthat, do you want to approach that one?
Well, I think
the ball.
most patients that I see in clinic, I would say, you have a mix of both. And again, this is before the definition of MetALD even come up on our radar, because those who drink or have problems with we call them alcohol associated liver disease, but they also have metabolic dysfunction or disorder too. So I think I agree with you. In basic science or in lab-based research, there are several several pathways are the same. Either you come from fat or you come from alcohol that lead to fibrosis, inflammation, or cirrhosis. But the upstream, I think, as you just mentioned, I see mix of both, unless you see someone that is so obvious that this is MASLD, MASH, or this is a pure alcohol. Again, it's going to come down to what you just said, I think you have to attacking both, do management of metabolic disorder and also using Bob expertise, how you can, take care of them for the AUD. I don't know, Bob, you have any thoughts on this?
Yeah, no, such an excellent point. These things do not exist in isolation from one another.
Yeah.
What we're seeing now is this combination of MetALD and alcohol use disorders, which the two together, 1 + 1 does not equal 2, 1 + 1 = 10. So there's a synergistic danger to these. So how do we help our patients manage diet and exercise? This is something they may never have had a chance to think about or practice or do. Alcohol is a lot of calories, but it's empty calories. There's no nutrition involved. So it isn't healthy, but it stops you from eating much. And then, once you're in recovery or you stop drinking, how do you eat healthy? How do you not just eat candy? I see a lot of sugar stuff going on when people first get sober. And I think people just need education, and it helps them to understand, that alcohol and the liver affects every aspect of their body's health. And the more they can learn about how to care for themselves, the better it gets. And one of the things that is exciting is when you talk to patients about stopping drinking, you say, well, are there things that have changed for you that you're good with, happy with? They almost always say that they feel better, much better. Even if they have cirrhosis, they feel better not drinking, obviously, with cirrhosis than they do drinking with cirrhosis. And I tell them that this is just the beginning. You can really change your life for the better and live a long and healthy life, but you have to learn the strategies. You have to know the tools, and there are ways of doing that that we can help you with. And so what we say to them is, you might have to quit smoking. You might have to learn to eat better. You might have to deal with a lot of financial issues that were going on in the past. You might have family issues and work issues. So alcohol is only one piece of the pie that we're dealing with them. So you're getting a sense, everyone probably understands that, not drinking isn't enough. That might be the most important thing for your liver health, but to keep you safe, to keep you healthy and make you as healthy as you can be, you have to address all these other issues too.
So I wanna push us a bit more on the health provider side, because we talked about the biopsychosocial model, right? And how that would be the ideal. How far are we from that? Is it happening? What do we need to do in order to provide that sort of comprehensive service to our patient community? Your thoughts on that?
I would let Bob go first. I think this is a very complicated question.
Well, so first, I just want to give a shout out to my institution. University of Pennsylvania has been extremely generous and very supportive of our work. And so we're really one of the only programs in the country that has these two arms of a treatment program, one being the co-located arm. We have a group that we call iLearn, which is Integrated Liver Education and Recovery Network. And that's where the psychiatrist and the hepatologist work together, and also social work is involved. And then on the other side, we have the treatment for the alcohol use disorder, specifically geared toward those people who have liver disease at the same time. Not a lot of places have that, which makes it, I think, a lot more complicated for folks in your position, Suthat, because you don't have the same kind of resources to send them to, which is the thing that feels so good and so important in your position. I mean, you're there to take care of their bodies and their livers and their minds, but it really helps to have somewhere to send them where people can take responsibility for some of these other issues that are so far reaching. And so really we have to move toward that model, honestly. That's been something that we've tried to do in our career for a long, long time. And I think the group therapy issue, or sort of the group therapy plan, is probably the least expensive and the easiest to transfer. Meaning that, if you have a program in your city or at your hospital, and you have people who can treat addiction, and you just spend, a couple days with them, have them shadow you in your clinic, Suthat, explain to them what it is you do and why you do what you do, and then have them go back and start meeting with these patients that you refer to them, you're going to see some amazing changes. And that's what we did. And the University of Penn was great in allowing us to do this, and they gave us the resources to do this. I think because in part they know that it's a lot less expensive to care for patients when you treat the underlying cause of the liver disease than if you just treat the liver alone. And it reduces rehospitalizations and all kinds of other expensive problems. So from the hospital administration perspective, it's a financial smart decision. And for the rest of us caregivers, we see it as a necessity, especially doing this in the team approach. When you do it in two silos, it just takes so much longer and it's so much less effective.
I think from what I hear is go back to the first slide that we talk about, multidisciplinary,
Yeah.
that, we need multiple people to work together for these patients.
And what Jen and Beth are doing is extraordinary.
Yeah.
I met them at a meeting and I was just so blown away by their energy and their humor and their optimism and their, real clear practical intelligence in what the community of patients with alcohol use disorders needs. They need to have folks who can provide them with evidence-based information, which we do, and they need to know they're not alone, which they do, and that there is reason to be hopeful. And for them to have started this group has been wonderful. And now we're starting to see a real terrific kind of tidal wave of care going to these patients, which they've needed all along. So
That's a great
see that. Yeah.
That's a great segue. And one of the
Talk
questions
about this peer support that Jen and Beth been doing. What is your experience about using telehealth peer support? Have you have any good experiences with that? And would that different than in person?
Yeah, we always think in person is the best way to go, but if you can't get there in person, it's better than doing nothing, that's for sure. And our group, that I told you about, that's just 12-step-ish based, 12 weeks individual and group therapy just for the alcohol use patients, that's all virtual. And so
Wow.
we get people all over the state, in New Jersey at the same time, and the groups are much more effective that way because they're all together. And you can decide for yourself if you feel comfortable turning on your camera or not. Most of the time they do. In the beginning, they might be a little shy, but we know that they can all come in. It's expensive to get into Philly from where they live 2-3 hours away. And it's also difficult because they're so sick, or they just had a transplant and they have a zillion, doctor visits they have to go to and all these other things. So it isn't such a stress on them. And I think that that's been a really good thing too.
Thank you.
Yeah, you're welcome. Great question.
I'm gonna ask Jen to also comment. Jen, over to you.
Thank you. And thank you, Neeraj, for putting this together. And thank you both, Dr. Weinrieb and Dr. Suthat, for joining today. I am just so happy that we were able to have you guys on today. I just wanted to express thank you, Dr. Weinrieb, for your wonderful comments in regards to sober livers. Yeah, that is one of the reasons I started Sober Livers, is to be like an adjunct support to these other treatment options that you have within the hospital for peer group support. And then, as you mentioned, a lot of hospitals don't yet have this type of support. The other thing is that I wanted to just ask, too is, as I did hear you say, that it's much harder for somebody to stop drinking when they have drinking still going on in the home. And, you know, I can attest to this. I have a nano brewery in my garage that is that has nothing to do with me, but has to do with my significant other, who he didn't start that up until I was already recovered for about 2 years. But at the same time, as you mentioned, you know, those are the times that are the most dangerous, right? So, you know, one of the things about sober livers, and luckily, I think because of my resilience and some of the other things I've been through with trauma and that I'm in therapy every week has helped me to survive this, is that, you know, to become this adjunct social support for when they don't have that at home. Are there any other recommendations that you have for people, you know, because we don't want to lose these people, right? And we still want to be able to transplant them if we can successfully get them the treatment and the support that they need. So do you have any other recommendations on how we can help these individuals that may not be able to change their physical surroundings and have to be around stuff like this?
Yeah, I think part of it is to have an open conversation with their doctors and their family members as a way of educating the family members and saying, you know, your loved one has gone through a life-threatening illness and they're here still, and we want to keep that going. And there are ways that you can help them. And if you feel like you yourself can't stop drinking or you're not ready to, is there some way the two of you can compromise? If you want to do your drinking, can you make sure that's nowhere near your partner? And when you get home, you don't go to the same bedroom, you go somewhere else so they don't have to smell it and see you in that condition. Or would you consider, you know, coming to a group with them? How about going to an AA meeting with them? And, you know, AA is not for everybody. So there's also Smart Recovery and other, you know, groups that are have a slightly different focus that you're probably more aware of than I am. But I think for me, the most important thing is to not keep this in the closet. It's to approach the patient and their family together. Not so easy to do, but I think if you come from a good place of help and wanting and care for them, they see that and they don't feel judged and they don't feel criticized, and neither does the family.
Right. Thank you. You know, and one thing I did, and I did not recover with AA. I recommend anything that helps anybody to recover from alcohol that's not dangerous for themselves or others. I highly recommend because we all have our own pathways to recovery. But one thing I did do is I went for a while to some Al-Anon. And that was actually very helpful for me to be able to focus on myself and what I can control and Stoicism has helped me with that as well. But, you know, I can't control this person. I can throw out the life raft for them, but I can't drown with them. And I learned some important lessons, although I don't go there anymore because I hate the word alcoholic, and I heard it a lot at Al-Anon. But I did find some of those lessons that I learned very helpful, and I'd like to integrate those types of things at sober livers at some point who are dealing with those things at home. So again, thank you so much for being here, Dr. Suthat and Dr. Weinrieb. I think this is extremely valuable information, so I really appreciate all of y'all.
Thanks, Jen. And Tiff, can we have the last slide? I know we had time and I want to be respectful of people's times. So, I mean, there's a lot of tools that are available and it's about people finding the right tools. But here's some key takeaways that we have, the previous slide. So, complex disease of psychosocial and biological dimensions. There's a spectrum of use and disease manifestation, multidisciplinary medical response that we talked about, psychosocial support and community engagement. And then let's go to our next slide. So please, all of the participants, thank you for joining us, and thank you, Dr. Weinrieb and Dr. Suthat. This was so informative. We will make this recording available to everyone, and please go onto our websites. There are a ton of resources available. There's never a perfect fit, but always take the positive that you can draw from different pieces and configure that sort of model for yourself as well. Any last words to our panelists?
Mm,
No, I would say thank you for having me today. Thank you.
yeah, I'm never at a loss for words. So it's a
Go for
dangerous
it.
thing to ask me this. But two things. One is that there are a lot of good things that you can read out there about alcohol use disorders and how to help yourself with them. And I'm hoping that some of those are on Jen's site. And if not, let's get them there so people can use that as a resource. And the last thing I want to say is that, alcohol use disorder is both biological and emotional psychiatric. And so the biological aspect, you can't change. You cannot change your genetics, but you can work to strengthen the other aspect of your life, which is the social. And the way I explain that to patients very quickly is it's as though your brain is a Weber grill with hot charcoal in it. And people who don't have alcohol use disorder, their brain might be a Weber grill that has cold charcoal. And when you put a little fuel on the cold charcoal, nothing happens. And a little fuel on the hot charcoal, you get a big flare up. And for the rest of your life, you're the hot charcoal grill. So you can't change it, but you can work toward the other stuff.
Oh, that's beautifully put. Thank you so much. And thank you all for joining. Please go to the website and get more resources.
Thank
Have
you.
a wonderful day. Cheers.
Bye.
Bye.